So I've been practicing HIV medicine my entire career. My transition or my introduction into telemedicine was the fact that I had HIV patients who were driving 3.5 hours one way to see me. And my response was, I'm not that good. You don't need to be spending an entire day, 7 hours, traveling, just for me to tell you that things are doing well. There had to have been a better way. And back in early 2002, when I was faculty at the University of California, Davis, I was introduced to Dr. Tom Nesbitt, who really has been the father of telemedicine in the state of California. And Dr. Nesbitt was gracious enough to introduce me to telemedicine, and I thought this was a really great way of delivering healthcare. So in April of 2002, we started an HIV telemedicine program at the University of California, Davis, where I was seeing my patients who were remotely located throughout California through telemedicine. Well, telemedicine is providing healthcare over a distance using real-time audio-video technologies. So it's seeing a patient much in the same ways we're interacting right now. So it has a tremendous application in infectious diseases. We're able to do inpatient infectious disease consults. We're able to do outpatient consultations. We're able to do program such as antimicrobial stewardship, and we've pioneered the concept of antimicrobial stewardship through telemedicine. In addition, we also assist with infection control as well as with ER diversion programs. So it's really all the aspects of infectious disease care can be conducted through telemedicine. Many hospitals require that they have a physician with the expertise to assist with their infection prevention and their infection control program. Many hospitals just don't have access to infectious disease specialists, exactly in the same way as antimicrobial stewardship. So what telemedicine does, it truly is a force multiplier. I know that's a term that's thrown around quite a bit, but it really is, because what it allows one physician to do who may be located in a large metropolitan area, or maybe even in a smaller metropolitan area, to now be able to offer that expertise services at a number of hospitals. Now, it's no longer geographically limited, because you can be at your desk and connecting through a telemedicine platform, you can be at 4, 5, 6 different hospitals that may be hundreds of miles away, all in the same day. We've been able to make real substantial changes in healthcare outcomes in patients. We've shown that through our antimicrobial stewardship program, where we've really been able to make sure patients are getting the appropriate anti-infective, help reduce cost, help reduce antibacterial resistance, reducing incidence of Clostridium difficile-associated diarrhea. All of these are very tangible healthcare delivery issues. But on a more personal level, we have numerous stories where we've been able to actually make an impact on an individual's lives. We've been able to diagnose necrotizing fasciitis. We've been able to prevent patients from being transferred hundreds of miles away from their family support unit, to be in their local community, to be able to get the health care that they deserve, the health care that they need, but yet still be able to have that support of their family. So telemedicine allows you to bring that expertise to the bedside, even if that expertise might not occur in that community. When we started our discussion, I defined telemedicine very, very clearly as telemedicine is providing healthcare over a distance using real-time audio-video technologies. I think the dangers are when people don't do that, when people use the term telemedicine and it's about a telephone call, when they use the term telemedicine and it's only about an email. Telemedicine is about seeing the patient, it's about delivering that healthcare. Now, there's such a thing as asynchronous telemedicine or store and forward telemedicine that is seeing patients not in a synchronous environment. That's very useful, and that can definitely improve quality of care, reduce cost, etc. But the danger is when people take what we've done in telemedicine and maybe try to make it a little cheaper, eliminate that video component of it, then you really have to reevaluate what the program is doing.